DMICE Informatics Conference, and our CI fellows are coming in right now. Our speaker today is Michelle Hribar, and she was originally trained as a computer scientist. She started working at informatics as a researcher before she retrained in informatics 10 years ago.
Yes.
It's hard for me to believe that. Since then, she has focused on informatics in ophthalmology, reusing EHR data to study clinical workflow, EHR documentation, and disease prediction. She is now completing a temporary 2-year position at the NIH as a data scholar at the National Eye Institute, focusing on the standardization of ophthalmology, EHR data, and imaging. Today, she'll tell us what she's been doing there.
Okay, thank you. Okay. Well, hello, everyone. As Karen said, thank you for the introduction. I'm Michelle, and I'll be talking to you today about what I've been doing as a data scholar at the NIH, focusing kind of on what I've been doing the second year. So to start off with, I'm sure most of you know that the National Institutes of Health is part of the United States Department of Health and Human Services. It is the largest public funder of biomedical research in the world. They budget, for example, in 2022 was $45 billion. I believe in 2023 it's up to $50 billion. It's over 200 years old and comprised of 27 institutes and centers. The Data Scholars Program is a program that's part of the NIH, and it was started in 2020 to advance data science projects at the NIH. And so each institute and center can participate. There's one project and scholar per year, and then the scholars can stay 1 to 2 years. So an institute or center could have multiple scholars at a given time. They work on individual projects as well as participate in the institute and center and NIH-wide work groups and projects. And just as an FYI, if anyone's interested in doing this, it is for anyone that already has an advanced degree. And you can apply. The application should be coming any day now for the 2024 cohort that will start in the fall. So the Office of Data Science Strategy is the place to look for those applications. So I've been working at the National Eye Institute, which was created in 1968. It's a world leader in directing and funding vision research. And for those of you, I think most of us know that, eye care and vision research is important. It has a huge impact on the quality of life. Blindness is among the conditions that Americans fear most. And the impact on science is really broad. I mean, there's been a lot of really great advancements I'll talk about later, and their connection to systemic health, not just eye health. So it's an exciting time to be at the National Eye Institute, particularly since the new director, Dr. Michael Chang, is an informatician and used to be here at OHSU. So I work in the Office of Data Science and Health Informatics at NEI, and that's led by Carrie Getz, and has a group of people that are working on diverse projects in data science. So data science is part of the National Eye Institute's strategic plan, and it interweaves essentially all of the different areas of research focus at the NEI, which is kind of exciting. And this is part of their new strategic plan that came out a few years ago. So it's very exciting to see how data has become such an important part of the work in eye care and vision research. So one of these exciting technologies that has become very important to eye care and vision research is optical coherence tomography, or OCT. It is a technique that uses light waves to create cross-sectional images of tissues, and it is used in eye care to look at the retina and also to look at the optic nerve. There's newer technology that adds called OCTA that also allows you to see actual blood flow through the vasculature in the retina. And this has really transformed eye care, particularly for retinal disease. In fact, OCT was sort of developed in tandem with when anti-VEGF injections started being used for AMD, diabetic retinopathy, that it was really the OCT technology that allows you to precisely inject that agent into the eye. So there's sort of a symbiotic thing of how both of those came to be. Now this has really been an amazing thing that happened, I think almost 20 years ago when it was first being demonstrated. And just this year, it has won a number of prizes. The Lasker Award, the National Medal of Technology and Innovation, and James Fujimoto, David Wong, who's here at KCI Institute at OHSU, and Eric Swanson. And I also saw, in these emails that come through OHSU that David Wong also got the award for an organ history maker, which is pretty amazing. And not to jinx anything, but these are always often steps before people get awarded like a Nobel Prize. So it's a big deal. And one of the exciting things about OCTs and how they've been able to be used, particularly OCTAs now moving forward, is this idea, it's called oculomics, where eye is the window to the body. So Carrie Getz, who's my boss, and you can kind of see her here, she went to this White House demo day, which she called a science fair on steroids. And it was a whole bunch of new scientific breakthroughs that were invited to present. It wasn't at the White House, but it was at a location in DC. And President Biden was there. There were different members of Congress. And and they got to demo sort of this OCT and the ability. Now, of course, they didn't do this live, but talking about they took OCTs live, but the possibility that you can actually use these to detect neurodegenerative, cognitive, cardiac, and circulatory diseases, because it allows you a view into the vasculature and the nervous system that's non-invasive, that we can't really get any other way in the body. So it's really exciting. And a lot of these possibilities are done with AI. They're not something that like humans right now could look at an OCT or an OCTA necessarily and be able to recognize someone with cardiovascular disease. This is something that a computer is really good at, and they've also done it with Alzheimer's disease. Now, eventually, at some point, if they can get enough insight from the models, humans might be able to detect whatever the computers are detecting. But right now, it's something that the computers can detect. But it's really exciting, and to me, it almost sounds like Star Trek, right? You can do the scan and it can tell you this, give you this sense of how healthy you are. It also is very exciting because it allows possibilities for improving access to care. But in order to take advantage of this, to develop both the AI that's needed, but also the insight from the AI and being able to do that analysis of what it is we're finding in these images, we really need these large, diverse data sets. So, and that's where my project comes in. And we really want to have data sets that really reflect all of the patients out there, all of, if it's retrospective data, that it's all representing all the practice patterns out there, the data diversity, because we really want to minimize bias. And the other thing is it also allows us, the more data we have from the more people, we can actually study rare diseases and outcomes in a way that we haven't been able to do before. So observational health data is really key opportunity for building these large, diverse data sets. Prospective data sets, like we'll talk about in Bridge AI in a second, are a step as well. But this is something, we can take advantage of all the imaging we've already collected during clinical care. And so my data scholar project was to improve the standardization of ophthalmic data that's collected in the EHR, along with imaging, so that we can actually harness these data sets for these exciting, research discoveries. So just to make sure everyone's sort of on board with what observational health data is, I find that sometimes when I talk to clinicians, they're not exactly sure what I mean by that. And all it is it's data that's collected during clinical care. So it's data that's in the EHR, that's entered into the EHR, but it can be everything else as well. I mean, a lot of the stuff that we don't even keep, like the monitoring data and, oops, how did that happen?
I don't know.
I swear that happens every talk. I think my computer is a little possessed. Anyway, so, but, you know, it could be patient-reported data, the genomic data, all the labs, medications, you know, monitoring, and then we can even connect it to external data sources to pull in more data about patients, you know, looking at, you know, like the ADI that's coming from census data or different social determinants of health, whether we're looking at it from a community level, we're asking patients, patient level. And then we can also, observational health data also includes the data that exists in all the insurance claims data as well. So we have all this data, but right now it's very siloed. It belongs to separate institutions across the country, across the world. And not only that, you know, it can be in very different formats depending on the EHR you have, but even if you have the same EHR, it's not always the same because each institution does their own sort of customization of that data. In fact, I was part of a study at the beginning of the pandemic trying to look at telehealth, and we were working with a group from UCSF who's also on Epic. And so they shared their queries with us and we ran them, and naively weren't checking very carefully. And the results were completely off because we implement billing data differently than they did. And so we were getting all these weird kind of artifacts in our data set because they weren't structured exactly the same way. So we have to be really careful about that. And it automatically advanced. So one approach to harnessing all of this is to pool them all together. Now, of course, this still requires some harmonization and getting all those to talk together. And there right now are some examples within the ophthalmic community of this pooled data. So the American Academy of Ophthalmology has the IRIS registry, which is a bunch of data that's pulled in from EHRs, mostly private practice. There are some from larger academic medical institutions, but they're mostly private practice. And the reason that so many of the private practice can contribute their data is the IRIS registry actually helps them calculate their clinical quality measures and get reimbursement from CMS. So that's sort of how they get their data. But there's also some other ones. Source Consortium is University of Michigan that collects data from academic medical centers that use Epic. And then there's these other national large data sets, such as All of Us and N3C. Now, the advantages are that they're large aggregated multi-site data, and data is accessed through a single point. So, you know, an individual researcher can, you know, a lot of times you have to apply or register to get access to this data. But then once you get access to the data, you can, you know, yourself touch the data, do the analysis that you want to be able to do. Now, the cons are that they require extensive legal privacy and security agreements. So, for example, OHSU started contributing to the IRIS registry. Gosh, it's been close to 10 years ago now. And it took, I'm not kidding, it took almost 2 years to get all of the legal agreements through. Same thing with the Source Consortium. We've been working, I think, even longer. I think it's been more like 3 or 4 years trying to get all of the agreements in place so that we can contribute our data to the Source Consortium. It really requires, you know, an ongoing effort at each institution to get that data sent and continually sent to that pooled location. And, you know, limited data is often shared because it's not very scalable. Like, you know, if you're trying to share like these OCTA images that I talked about, these are large 3D scans and they're huge files, they're gigabytes. So it's not practical to try and send all of these images to one central site. And then we still have, you know, like I said, you still need efforts to, you know, try and harmonize all this data that's not all speaking the same language. So the other approach is to keep the data distributed, but instead each institution keeps its own data, but then they share the analysis code instead. So there are examples of this. The Odyssey network, the Observational Health Data Sciences and Informatics network, that's what they have been building over the last 10 years. And this is actually across the world, not just in the US. And there's some other examples of the Odyssey network that are more focused, like PedsNet and Eden, which is the European one. Now, the advantages are that it's very scalable because we're not sending data anymore, so you can kind of keep your data local, and so you can, and you have a lot more control over, what you want to actually share. And it also involves these complex data sharing agreements. Now, you still have to have something in place that allows people to access that and get approval for it. But because the institution is not sending that data anywhere, you don't have to go through all the institutional legal stuff. You still have like what's more like an IRB, like an individual researcher kind of agreement. Now, there are still some cons to this. It's not perfect. You still have to have a lot of resources in place at each institution that standardize, because you have to put all that data into a standard format so that it can all share, if you share the model, that it will work on all the data. And you need resources in place at each institution to help run each of those codes, or you have to have a partner, like a researcher partner, that's going to run your code on each site. So, there's pros and cons to each approach. But what we've been, because the ophthalmic community has already worked so much on the pooled one, and they're so focused on these imaging, they really wanted to build out this distributed network availability, particularly of these large images. So in order to do any of these approaches, like I mentioned, you have to have some way of harmonizing your data. Standardizing the data is really key. There's a lot of common data models that are used. And the one that we've been focusing on is OMOP, the Observational Medical Outcomes Partnership Common Data Model. And that's the one that's behind the Odyssey network. So OMOP was started as a public-private partnership for 5 years. And it was the NIH, the FDA, pharma, and academia were all part of this. And then what they were trying to do, their goal was to be able to do, to extend their ability to do market surveillance of medical products after clinical trials. So be able to look at claims data, EHR data, to see how their products are being used, monitor adverse outcomes, monitor, the actual treatment, the treatment outcomes. And so what came out of that partnership was the OMOP Common Data Model. And since then, so it's just a standardized structure of a database that stores this data, and it includes the conventions for how to put that data into this standardized format. And it's also been widely used in a lot of projects, particularly like the NIH data generation projects, like All of Us, N3C, and BridgeAI, and I'll talk about that in a second. So Odyssey, the Observational Health Data Science and Informatics community, that's the group that kind of was formed after the OMOP partnership ended. And so they have been maintaining and developing, this open source community has been maintaining this data model for the last 10 years. And they have done amazing things in terms of not only maintaining this like rules for how you store this data, but then all of the tools that are built, like once you have that data standardized, they have built all these tools on top of that allows you to use that data appropriately to run these data, these studies at different sites. You can publish it, and then it's very easy for people to run it. And to also make sure that you're accessing the data in a standardized way and standardized phenotypes. And to date, it's really supported thousands of studies, which is exciting. And so in our community, we had last year, one of our researchers, Cindy Kai, she's a retina specialist and informatician from Johns Hopkins. She did the first network study in eye care and vision research as part of the SOS challenge that the Odyssey community was running. They run these initiatives every so often as a community. And so she picked a question that was answerable given the data that already exists in the OMOP CDM. So it wasn't using any eye exam specific data. It was using data that would be available in like claims data. So things like diagnoses, medications, that procedures, that kind of thing. So she was looking for so anti-VEGF, as I mentioned before, is used in intravitreal injections for different blinding eye diseases. And they know from its use in oncology, they can have adverse effects on kidneys. But they don't necessarily have a lot. They have some small studies that have shown sort of this impact when it's done intravitreally, but not a lot. So there's 3 different agents that she compared: ranibizumab, aflibercept, and bevacizumab. And the ranibizumab has a much shorter serum half-life, like on orders of magnitude. And so, but it's also like 20 times more expensive than the other 2. But a lot of times, patients that they're worried about being at risk for any kind of kidney effect or injury, they'll preferentially prescribe or inject that, and which is a much bigger cost. So our question was, and the hypothesis was, that ranibizumab should have much fewer adverse kidney events in the population. So Cindy wound up looking at 12 different databases that represented 485 million patients. This was all done in the course of 9 weeks. And she was able to find 6.1 million patients with blinding eye diseases. And you can see here that there's, the ranibizumab wasn't necessarily prescribed most, the bevacizumab was, but you could see that there were 1,200 kidney failure outcomes. But when they did the pairwise comparison between all of the different agents, there really did not show any difference or any increased risk of the adverse events for any particular agent. So this was just published, and it's sort of an exciting outcome for the community. It's unclear if this will drive some prospective studies to confirm that, but it's definitely something that the community is interested in because it represents a potential savings in healthcare spending. So, and this sort of brings up what I just mentioned, these layers of data that are available in OMOP. So the claims data is sort of at the core and a lot of where they started, the data that you can get, the diagnosis, the prescriptions, the procedures. And then there's also there's another layer that's available in EHR. So it'd be like vitals, lab results, that kind of thing. And that sort of that standard, or that current OMOP, that sort of the orange and the yellow, is sort of what they call vanilla OMOP, or what's sort of available now. What we've been trying to do in the last year is expand that to include the ophthalmic data, or the eye exam data. So things like visual acuity, intraocular pressure. And then the blue would represent also including the imaging and how to integrate that. So and each expansion of data allows you to ask more and different research questions, right? So like if you wanted to compare, for example, those 3 anti-VEGF agents for their treatment efficacy, you couldn't do that right now, given just claims data or EHR data. We would really need to have some measure of the actual treatment outcome. So those are the types of things that we want to be able to do. So, and the exciting thing is that just about a year ago, not even a year ago, the Odyssey Medical Imaging Work Group has proposed a reference standard for how to incorporate imaging into OMOP, which hasn't been done yet. So they are working right now, and we're working with them on how to pilot that. And particularly, they're doing it right now for a data set that has for MR, and we're trying to see if we can do it for OCTs. So as a first step to kind of creating that network of having those images available. Now, there's a lot of challenges for this, even for the EHR data. The data is obviously named and stored differently in different EHRs. For example, in Epic, when you enter in a visual acuity, it's just a free text field. So you're entering in 20/20 or no light perception, all in the same text field. In Cerner, we've been told, now, I haven't seen it myself, so I can't confirm, but they actually enter the numerator and the denominator separately. So like 20/20 would be 2 separate boxes, which actually kind of improves their data quality a bit. But we still have this problem. We have all these different ways of entering this. We also have this problem that so OMOP is built on top of standard terminology. So things like ARCS norms, SNOMED, that sort of thing. We don't have full representation of a lot of these elements, even in those source terminologies. So we can't even add them to OMOP yet until they exist in the source terminology. So we've been working on that. And the free text fields are a bear to actually get data out of. And as I mentioned before, like a visual acuity that can be a fraction, or it can be, valid values include, like 20/20, but also could be counting fingers at 10 feet. I mean, that's a lot of different, things that you have to look for. And then the other problem is that some of the data doesn't even have structured fields available for it. So it only exists in notes, but then there's also different users who preferentially put it in notes, not in the structured fields. So imaging data is also a real problem in eye care, because most of especially the OCT imaging does not perfectly conform to the DICOM standard, which is, what you'd expect. So a lot of the devices use proprietary tags and will wind up doing encryption. So you can't actually get at those tags unless you're looking at their viewer. And it's kind of a big problem. So this is something we've been trying to tackle through a series of different workshops. And, the FDA and the ONC and the NEI actually held some workshops with vendors to try and see what we can do to kind of move away from to move more towards a standardized way of representing imaging. And then, as I mentioned before, these volumetric scans, these 3D scans, are very large and difficult to share. So 2 years ago, we started the Odyssey Eye Care and Vision Research Work Group to focus on these, to improve the OMOP Common Data Model. And it's really a multidisciplinary group of researchers in eye care and vision research. I think we're up to 144 members. But I would guess that it's between 40 and 50 that are really actively participating. And it represents a really wide range. So there's ophthalmologists, there's optometrists, there's trainees, there's informaticians like me, and vision and data scientists as well. And we've all been working on standardizing this data, trying to improve the representation of the data and standardized terminologies, and also looking at how
We're back.
We're back.
Hi all. Can somebody confirm that they can hear us?
We can hear you.
Great, thank you.
No.
And to share. Okay.
There we go.
Okay.
Sorry about that interruption. Not sure exactly. Just got dropped. We've been working together to standardize the uses data, create phenotypes and start to do these analyses. And really the goal is to support data sharing and interoperability between sites and across the world. And really to create, our goal is to create these better data sets. And also to get ophthalmic data. So for example, all of us does not contain very much ophthalmic specific data because it's not yet part of OMOP. So we really are pushing to get that into all of us as well as create a distributed network. So we currently have 6 subgroups that have been working on this in parallel, focusing on different disease subtypes as well as looking at imaging and ETL issues. We've done some initial mapping work, and this was also done by Cindy at Hopkins, and she looked at EPIC and looked at all the fields that were in the eye care part. It's called Kaleidoscope module of EPIC. And, you know, looking at that, it was a very small percentage. It was like a quarter, only a quarter actually had an equal or like actually an exact match in like SNOMED or LOIC or some standardized terminology. And the rest were, so one of the biggest challenges are, you know, is that a lot of the code is missing important modifiers. So for example, like visual acuity, there might be like distance visual acuity, but it's missing laterality, like whether it's right, left, or both. It also might be missing whether or not it was done with correction or without correction or with pinhole, without pinhole, that sort of thing. So it's not, you know, these wider things were that it's not necessarily like there were no concepts related to that. It's just there weren't specific enough ones. And then there were some that were just completely unmatched. So we have some quite a lot of work to do that we've been, so they've already submitted some things to SNOMED for both retina and working on it with glaucoma. And we're looking at adding visual acuity concepts to LOIC. We've also been doing some work, even though we don't have everything fully expanded into OMOP yet, we've still been looking at identifying and defining phenotypes for these different types of diseases. So even though we can't necessarily do this in OMAP yet, we still feel like it's a really important exercise to really standardize, like when we say, you know, someone has uveitis or a particular type of uveitis, for example, what are the diagnosis codes or conditions that we're looking for in the EHR that's going to define who these patients are, and trying to make sure that they're kind of aligned. So and then people can actually use these. There's a tool in Odyssey that allows you to kind of create these phenotypes, but then allows you to kind of export SQL code, so then you can adapt that SQL code to run in your own environment if you don't actually have OMOP. And so we've done this for a variety of different diseases. We're working on a lot more right now, such as amblyopia, high myopia, juvenile idiopathic arthritis, associated uveitis. So it's been an interesting thing looking at the data to see how we find our patients. And then we've also been focusing on, as I mentioned, including these ophthalmic data in large data sets. So Bridge to AI, which is right now having their big open house meeting in Bethesda. So that's why a bunch of us, like Stephen Bedrick and Shannon and Bill Kirsch, are all up in Bethesda. And there's actually a public option tomorrow if any of you are interested in learning more about the Bridge to AI data sets. I'm planning on joining virtually. Unfortunately, it starts at 5:30 in the morning for us, but this is my life. I'm often, the worst was 4 a.m. But, you know, if you want to see these data sets, not just the one that I'm going to talk about here, but there's, I think, 4 data generation projects in Bridge to AI. And they're all supposed to be releasing their pilot data this month or soon. So it's an exciting time to get some access to some early access to some data. So the one that relates to ophthalmology is the AI Ready project. And this is a project that's creating a triple balanced prospective data set of 4,000 diabetic patients. Now, of course, the pilot data only, I'm not exactly sure how many hundred are in the first, pilot data, but they're collecting, it's balanced for race, gender and severity of diabetic disease, but they're collecting a whole bunch of data. So they're collecting a bunch of survey data about patient history, different patient reported data. They're collecting a bunch of objective exam data that relates to diabetes, but also just normal health. And they're collecting eye exam data, and they're collecting eye imaging. They're also, I believe, getting Fitbits and continuous glucose monitoring. I mean, it's going to be a really rich data set that will, I think, lead to a lot of different scientific discoveries. And they're doing this in OMOP. So a lot of the things in our work group that we have been trialing, they have been implementing in how they structure this data set. Now, granted, this is the data set, not, trying to get EHR into OMOP. So for a lot of the data elements that they're collecting, there really isn't an exact match in EHRs, because when you're doing research on patients, you collect visual acuity in a different way, for example, than you would in the clinical setting. But that's been exciting to work with them. And then the All of Us data set, which I think a lot of you know about, that one didn't have any eye exam specific data because it's not well represented in OMOP. So we've been working on trying to figure out how to get that in there. But the big thing is we're going to, the NEI has bought, I think, 4 OCT machines that will be deployed to a couple of to several pilot clinics. So they'll start as part of the intake, and also when patients will come back for follow-ups, they'll be getting an OCT image as part of the data that's available about them, which is pretty exciting. And then finally, to support this more distributed network, this is what our goal is. We'd really like to build an ophthalmic data network. And to start off with, we envision this being kind of available at a fixed number of sites, say 4 or 5 different sites that have agreed to, put their eye exam data from their EHR into their OMOP data mart and put their imaging or certain types of imaging into that data set. And then the data coordinating center would help with getting all that data in there and making sure it's consistent, and with running network studies. But also, it would also include tools that will allow us to use this data appropriately. We really think we're going to have to extend some of the existing Odyssey tools to work with eye exam data, particularly because laterality is such a huge deal. And we'd want to make sure we're supporting that well. So it'd be adding our own little extension to make sure our data is handled properly, but also include tools that would allow for federated learning. So we can both find the images at a site that we would want to run our, AI on, but then also making sure that we can run that distributedly. I also think there's potential for some tools that will allow us to do data curation of those images, because a lot of times you have to go in and make sure that they were segmented properly and all that stuff. So we're going to figure out all the tools we need to support this. We're really excited about this, and we think there's a lot of real great ways that we could use this. The first one we think is kind of the most obvious one, which is sort of the way that OMOP was conceived in the first place. So when you have these clinical trials and you've tested your treatment on this very small, restricted set of people that often have, they don't necessarily represent the population at large that is actually going to get that treatment, because they're usually they're not on other medications, or they're newly diagnosed or something like that. So, once these treatments are actually used in the broader population, first of all, what are the practice patterns for that? How do the outcomes match or correspond to what we actually saw in a clinical trial when it's used in a different population? That kind of thing. The other thing, if we can have more imaging, everyone always wants more imaging data sets, because a lot of the AI models that are built on these data sets, there's often not other data sets available for validation. So even if our network just provided a validation option for people, it can be very powerful. We think it can do more than that. That would be a really important thing. And, we really we're excited about this oculomics and being able to tie, the OMOP data marts we're adding eye exam data in there, but there's already all of the other data that's already in there, their inpatient data, their primary care data. Now, of course, we have this fragmented data problem in the US, and Odyssey, this is a problem with all Odyssey studies. Like you can get your eye care at a different place where you get your primary care, for example. So, we'll have to, that's going to be a challenge. But assuming for the patients that you get their eye care and primary care and inpatient care at the same institution, we can have pretty good data there. We also think it's a great way to study rare diseases, but also we really we think it's an opportunity to improve prevalence estimates because the way that they're often done now is for some diseases isn't quite exact enough or fine-grained enough to tell differences between different severities, for example, that kind of thing. So we'd really like to do that. And also I think my interest is in how we can study healthcare access and equity and potentially improve it. So the impact is a lot of the same. So I probably will, this really is going to enable a lot of different research, both for eye care and the intersection of how, what you can see in your eye or your retina and your systemic data or systemic health. And so, but there's a lot more work to do. So the Odyssey community there are thousands of people that belong to this. There's already a lot of working groups like ours that focus on particular parts of either the OMOP common data model or different clinical areas. But there's still a lot of areas of healthcare that really aren't represented in these working groups and aren't necessarily doing what we're doing to try and make sure that the data that you need to do your studies is actually part of OMOP. So there's still a lot more opportunity for expanding OMOP into these other medical specialties and diseases. So, anyone can get involved. It's a great collaborative community. One of the things I really love about it is that it's so welcoming, and it's particularly welcoming for trainees and students. So it's not unusual for trainees and students to be running or leading like these big projects. And often it's because trainees and students have more time than the rest of us do, but it's a great community that really supports everyone. So it's great. You can join any Odyssey work group, you can join ours, you can join other ones that are more aligned with either your research or clinical interests. And even if you're just curious about it, a really great place to check out what's going on is the community calls page. So every Tuesday morning at 8 Pacific time, they have a community call that updates the community on all the different efforts that are going on. Now, of course, it doesn't represent everything every time, but there's always some focus to the meeting about something that's going on to let people know what's new and what's coming. So just in summary, research and eye care really requires these large diverse data sets. There's a lot of really exciting opportunities, especially given the advances in ophthalmic imaging. And I've been leading this work group that has been focused on trying to improve the standardization and harmonization of ophthalmic data. I still want to hopefully continue this work once I'm done with my data scholar position in September, but we'll see. There's still a lot more work to do, and there's a lot of people involved, so it's kind of exciting. So anyway, I think that's about it. So if anyone has any questions, I'd be happy to answer them.
Any questions?
Data standardization has been, it's like the bane of research existence in terms of medicine, in any field, because it always, our definitions change, they get more specific. Like how sustainable is the current process for continuing to update our terminology?
Yeah, so the question was, data standardization has been a problem for a long time, and part of the reason it's hard is because things change over time in terms of our definitions of disease and how do we maintain that and update it over time. And a good example of this is that a lot of the things that are missing in eye-related exam data in these standardized terminologies are new. They're measurements that are new because we have this new imaging available. So it's not just that people change definitions of disease as we learn more. It's also that as we improve technology in ways that we can actually assess health, we're actually creating new concepts. And this is something that it's a bigger problem than just, putting like the Odyssey community or OMOP. And there's a lot of different efforts that are looking at this, and we're looking at this from a lot of different angles. So I just talked mostly about the OMOP common data model, but so the NIH right now, as a lot of you probably know, is pushing these data sharing plans and really encouraging people to share their data. And part of that in the future is probably going to include using what they call common data elements. And so common data elements are these data elements that the community has decided are the way that we want to collect, this information about patients. The idea is NIH is going to be creating a CDE repository that's going to be available both, kind of initially, or their initial use cases really focusing on that prospective clinical research and collecting data and trying to make sure that there's some kind of standardization, and we're not collecting race in 10 different ways, for example. And so we've got that, and there's going to be, I think there's still going to need some work in the process of how those CDEs get submitted and how they're maintained over time. So they're thinking about that and working on that. The other thing is the ONC maintains this USCDI, which is right now a set of data elements that all EHRs are supposed to be collecting about patients, right? And that is sort of like what we think of as sort of a subset of what the common data elements are. Now, the ONC is going to be allowing you to do what they call the plus of USCDI. So for individual areas, like they already done one for plus quality, I think, for CMS and quality measures. So they're not necessarily going to enforce them the same way they do the general USCDI in terms of EHR compliance, but it's more like a recommended roadmap of, okay, so we're going to be hopefully working on something called USCDI plus I that's going to identify what eye exam elements should be collected in an EHR, how they should be collected, what source terminologies they should be mapped to. And those also is for those of you that are into FHIR also is very closely tied to the USCDI, right? So there's all these different kind of things circling around the same problem. And this is one of the things I've been asking all the time is how do we make sure that we're coordinating, everybody's working together, and that we have some process that works over time. Like we can standardize everything as it looks right now, but 5-10 years from now, things are going to change. And who's going to make sure that, all these things get updated consistently and that everybody gets the memo, right? And I think we're still figuring that out. So sorry, that's a really long answer to say that a lot of people are working on it and know it's a problem, but we realize there's still a lot of coordination.
Any questions online?
No, not yet.
So I do have a question. So these databases you're talking about are pulling in from primary care and ophthalmology. I mean, they're getting all of those key data because it would seem like some of the things that are stored in primary care, hemoglobin A1C, would be important and relevant with the ophthalmology data.
Yes.
Oh,
Yeah.
repeat the question.
Oh, yeah. So, okay. So the question is, there's already, primary care data that's in OMA. Now, that's true. I am not an expert in it, so I don't know if, like, there's probably some areas of primary care that maybe feel like are missing good representation and good, so it may not be perfect. But like, yes, you're right. You can get blood pressure, you can get A1C values, those kinds of things. And just to step back a second, a lot of academic institutions have an OMOP data mark. OHSU does, for example. They already have one. OHSU created one as part of their efforts to contribute to the N3C, the National COVID Cohort Collaborative in 2020. That actually supports a number of common data models, but we decided to use OMOP before we contributed that. And I believe a number like UW at the same time also got an OMOP data mart. We were actually working with them on that so they could also contribute to the N3C. So we're not necessarily, we're hoping to piggyback off of that, right? But surprisingly, like you bring up A1C, one of the things that's really surprised me is that I don't know how much ophthalmologists actually even look at A1C. I think they're more focused on what they can see in the eye. Now, of course, they care about it in the sense that uncontrolled diabetes is obviously going to have higher risk for diabetic retinopathy, but and they definitely want to get that under control, but they sort of leave that up to primary care or endocrinology, and then they kind of work on the eye impact of that. So I was a little surprised about that as well, that doesn't factor in more, but that could be my own naive. I'm not, I haven't done a whole lot with diabetic retinopathy, so maybe they use it more than I think they do. But yes, that data is available. We could use it.
Any other questions? Thank you.
Your retina specialist, I'm going to sleep into that. Like, it's in seconds. I have a friend from college who's a retina specialist, just graduated.